Good morning all, and thank you for the introduction. I'm pleased to say that whilst my hair is grey, I do have a bit more than some of my partners, as you will see as we go along. And I'm going to talk about the unhappy total knee, something I believe it will be familiar to all of those who are present here and also on the webinar, because it's a very common problem. Now, if we look at the natural knee, it's really quite a marvel which has evolved through the various stages which we can study in the zoo. It connects two long lever arms. It actually has to withstand huge forces in terms of the twisting, turning, and sideways movements. And so it's not surprising that after years of use and abuse, we end up with the arthritic knee, which may be injured or inflamed, stiff, painful. And you've seen those as well. And when we take x-rays, we see that there's no more cartilage left, and it's not surprising that they're painful. So that brings along the artificial knee. Now that's quite an engineering challenge. Surprisingly, if you look at the new knee replacements, they look exactly like the old knee replacements, which guess what? Look exactly like a knee. How else should it look? So the real advantage in terms of the knee replacement has been tribology, which is the science of the gliding surface, or in our case, really the plastic in between, and it's the cross-linked poly which has given us knees which last a lot longer than we predicted in the past. Now, those who've been here in previous lectures know that I'm also a fan of the AOA National Joint Replacement Registry, which is in Adelaide, and every single knee and hip and shoulder replacement is reported to the registry. The registry does a very detailed analysis, and it always takes a year or more before we get the report. So if I look at the 2021 report, which was the latest available, we did nearly 60,000 total knees in that year, most of a slightly preponderance of females, mostly over 65 years. Very few in the younger age, but we do have some people under 55. Mostly these days in Australia, patella is resurfaced, although that varies very much from country to country, because if you go to Norway, it's only 4%, and in Sweden it's 7%, and in England it's 60%, and the US it's probably 90%. Mostly we have cemented knees, and the hybrids perform the same as the cemented. Now, the good news is that although we've had an increase in the number of knee replacements, the revision rate has actually decreased, and we believe that's due to better surgery, but also due to better tribology. And we can now say to many patients that if they have a knee replacement, it will last their lifetime, because statistically speaking, at 20 years, the revision rate is 8%, which means if you turn it around, 92% of knees are still working at 20 years, which is pretty good. You will hear a lot about computer navigation and robotics. There's a lot of advertisement of this, and the registry has shown a very small improvement of the outcomes with the robotics. That's a little bit complicated, because often it's the very good surgeons who start using the robotics, and their figures were already better than the average. So we're not yet sure whether robotics actually are affordable in our community. And even though the companies provide them often so-called free of charge, there's of course added into the cost of the prosthesis. Now, the registry also provides figures for individual surgeons, and incidentally, you could ask your surgeons what are their figures. So here you can see, and I'm quite happy to show these, that my own revision rate is a lot lower than the average revision rate. We've only looked at surgeons' figures themselves for the last 11 years, and that's why there's a discrepancy between the length of my figures and the length of all surgeons. For the last 3 or 4 years, we've also collected patient outcome forms, and here you can see on the left are my pre- and post-operative figures. That is of a sample of my knee replacements, and these are actually collected quite independently of the surgeon. And so we can see that on the whole, people are better off afterwards. And they also look at patient satisfaction. And here of a sample of 110 patients, again, quite independently, much to my surprise, up there, that little diamond are my patients. And I could say how great that is. However, patient satisfaction is very complicated. And on the whole, we probably say that 80% of patients are very happy. 20%, however, are unhappy. And if you say that we do 60,000 a year, that means we've got 12,000 patients every year who are unhappy. And those are the ones who challenge us. There may be residual pain or stiffness, sometimes even instability, especially when they walk stairs. Sometimes patients are worried about the clicks, which are very common, and probably because the hard surfaces inside the joint knock against each other. And some people also worry about the scars, and some scars are quite unsightly, but that's actually more dependent on the patient's ability to heal well. And altogether, we probably think that a lot of these are unmet expectations, both of their physical and their emotional reaction to the operation. And in fact, it's the emotional bit I'd like to spend some time on today, because I think we don't spend enough time on that. Now, there are some problems for surgeons which lead to unhappy knee replacements. For instance, oversizing of the femoral component makes it very hard for that patient to flex the knee. The patella has a much bigger excursion to go through. Positioning of the femoral component in terms of rotation is also important, especially with patella gliding. We spend a lot of time intraoperatively balancing the knee in flexion and extension. It's probably true that some of the robotics, or at least the navigation, which is part of the robotics, helps in that regard. There is maltracking of the patella, and you may see that patella off to the lateral side, and also patella problems walking up and down stairs. Then, of course, bleeding, infection, and fracture, intraoperative fractures. These are problems for the surgeons. Prosthesis failure as such is actually quite rare. In the PS knees, the posterior stabilized knees, which rely on a plastic peg inside to stabilize, occasionally you get a peg fracture, which is difficult to diagnose because you can't see the plastic. And then there can be dissociation when the plastic wafer comes off the patellar component. These are quite dramatic events. Poly-wear takes a long time, and metallosis really only comes about when the poly is gone, and now you have grinding of metal on metal, which causes trouble. And all these are really problems for us as surgeons. You might see them, but these are patients who need to be referred. Infection you will see more commonly. Infection in a primary knee replacement happens in about 1 to 4%. In the revisions, a little more common. You will see red knees, hot knees, painful knees, and I think if there's any suspicion, even here on this picture, you see only mild erythema, but at 6 weeks, that is a worry, and those people need to be referred to the surgeon. These people need urgent attention in terms of investigations. Usually the CRP is the main indicator for us that there is a infection, and we will deal with these with aspiration and washouts. Periprosthetic fractures actually present usually late. These are people who've had happy knees for a while and then they fall over. This is quite dramatic on this picture, but you get minor fractures, sometimes also avulsion of the bone of the medial or lateral collateral ligaments. There's a sudden increase of pain in the knee, which was quite good. And again, if there's any suspicion, these people need an X-ray and they need to be referred to us, the surgeons. Problems which you see much more commonly, of course, are stiffness. You'll see weakness. People have trouble, especially with stairs. That's where they mostly complain, or just getting up from chairs. Abnormal gait. And some of these people need reassurance. They need a bit more time. One needs to talk to them. The stiffness, which we worry about, is that they have still less than 90 degrees of flexion, or more than 10 degrees of a fixed flexion deformity. And the factors which you can't change are, of course, those who had had a stiff knee prior to surgery, because the preoperative range is probably most predictive for the post-operative range. Previous surgery, surgical errors, as I've mentioned earlier, and propensity to scar, which some people have, are factors which are difficult to change. There's, of course, also concurrent disability. People who have Parkinson's, strokes, other neurological conditions will make all this much more difficult. Now, factors which I believe you can influence as physiotherapists, you can help us actually create realistic expectations. We talk about this a lot amongst surgeons, and patients need to know that even though they have a good knee replacement, that you're not going to make them younger and you're not going to give them back their perfect knee which they had prior to their arthritis. We can improve pain management, and we should set a realistic time frame for the improvement, because knee replacements do take 3, 4, 5 months before people are actually able to do all the things they want to do. So we need to set that time frame, and you help a lot with physical training, but you also need to help us to support the emotional state. And you'll probably have patients, and you know who I'm talking about. These are often difficult patients, and we need to see them probably more often than those who do well. And also, whilst I get a lot of calls from physiotherapists about can they go to hydrotherapy, can we start the bicycle and so on, it probably is worth talking to GPs or surgeons about the emotional state of those patients, because some of them are struggling and they can be helped. Now, manipulation under anesthesia, when do we do that? When we have progress and progress stalls, and that's again when you should ring us and say, look, we come to a block here, we've come to at the end of what we can do. Sometimes it's just pain which stops patients, but sometimes it's scar tissue which forms deep inside and is so tight that we need to break that. And it's best done at sometime between 6 or 8 weeks before that scar tissue becomes so tough that it actually becomes difficult to break. And in fact, it's a mechanical thing. It's quite satisfying for the surgeon. It makes a bit of noise. The patient is asleep. But you think you can actually feel you've done something for these people. It's a day-only procedure, and these people need to come back to you early for resumption of their physiotherapy. We used to use continuous passive motion machines, but they've gone out of favor because it's too difficult to keep patients on them, and probably patients who are stiff cheat a little bit with the angles because it never really holds them tight enough. Now, just a little word about hypersensitivity, because people have asked about this, and patients sometimes worry that they may be allergic to their knee replacements. And of course, people do have allergies to nickel, cobalt, and chrome. It's actually quite difficult to prove. Skin tests have not been reliable, although there are allergy clinics out there doing such testing. Serum levels are very low. It's difficult to say. There is a little bit of a worry in the background, and especially in Europe right now, there's a big drive to look at the data, whether cobalt in particular may in fact be carcinogenic, and we don't know as yet, but it's definitely a worry because many of the implants which we use, especially in the knees, are actually cobalt alloys. So a common cause of unhappiness in our patients, well, patients fear pain. They worry that the more they move, they might be upsetting their knee replacement. They think that pain is a warning for something bad to happen, and we maybe have to talk them out of that. Anxiety and depression seems to be a part of a pandemic in our community right now, because lots and lots of people getting treatment for that. And of course, those who are already on treatment will do worse when they have pain or when they are in a situation which is unfamiliar to them. They've lost control. They're now in your hands or in our hands, and they need help with the psychological setting. Unrealistic expectations. I thought I was going to be playing golf in 2 weeks or 4 weeks or 6 weeks. We need to say, look, very few people are. Yes, there are a few fast ones, but It's a bell curve distribution of how quickly people improve, and it's not a race, it's not a competition. Some people struggle with comorbidities or social circumstances, and the more we know about who these patients are, the more we can actually help them individually. Some people lack exercise, and very rarely we have patients who have pain because they've been overdoing it. So those patients who only had mild arthritis prior to their knee replacement generally do a little worse than those who had bad arthritis. And you can imagine if you have a lot of pain and you get better, you're much happier. High BMI may cause problems because those people have such big calves and thighs, they can't actually get that range of motion. People talk about their pain scores, and usually our experience is that those patients who tell us that they have a high pain threshold actually have just the opposite. Previous surgery is another bad indicator. So we have the challenging knees. Some knees look bad, but they actually feel good, whilst others, in fact, look good, but they feel bad. Sometimes we spend time on and money on investigations, blood tests, CT scans, and all the rest, but it remains inconclusive. But remember, the unhappy knee actually needs to be heard. Who doesn't know a patient who catastrophizes? Everything's going wrong, everything's bad, I can't cope, I can't manage. This is the loss of control, and of course knee replacements has effects on their whole life, not only their knee, but they're out of work, they're out of sport, they're in sometimes in an isolated situation because they live by themselves, and then of course the internet has led to intervention overload. Prevention, as always, is better than cure, so we have to be careful with patient selection, preoperative planning, postoperative care, and, as I've emphasized, is communication. So unhappiness may have some physical causes, which we are happy to address as surgeons, and emotional causes from which we often shy away. The teary patient, the angry patient, the difficult patient, they actually need more care and not less. As physiotherapists, you are multitasked. You are teachers, both preoperative and postoperative, trainers, coaches. You are patient advocates, counselors, and you are often the patient's friend. So good outcomes require teamwork, which means you, GPs, surgeons, and others. The unhappy patient does need us, and we should respect not only their body, but also their minds. And feedback to patients and doctors is most important. Some, of course, need proper psychology and also drugs to support them. We need to take time to listen, individualize treatments, and share the problems and solutions. Communication is really what will make some of those patients happy, because that is not only in the knee, but in many other medical conditions, the clue. So on behalf of the unhappy patients, I encourage you to take more note of their emotional state. Thank you very much.